Aryati. I come from Indonesia. I'm a clinical pathologist and infectious disease consultant. Thank you. I have an opportunity to share my topic about diagnosis of dengue virus infection, especially with IgA anti-dengue rapid test. Why rapid test? Because in my country, we need a simple test that we can have a high validity. And this is the world map. We know that the Aedes aegypti mosquito with dengue virus inside usually exists in a tropical and subtropical country, include Indonesia, where I am from. And this is Indonesia. We have so many islands. And I live in a Java island in Surabaya, near Bali, perhaps. Usually people know Bali, but no Indonesia. If a patient comes to the doctor with 3 days of fever, sore throat, myalgia, so what is diagnosis? It could be malaria, it could be chikungunya, it could be leptospirosis, it could be upper respiratory infection, it could be dengue virus, such as dengue fever, or dengue hemorrhagic fever. All of the disease in my country, we know there's a dengue virus infection, can asymptomatic and also symptomatic. After incubation period from the bite mosquito 4 to 7 days, it could be undifferentiated fever, dengue fever, or dengue hemorrhagic fever. In the grade 1 or grade 2, no shock, but if grade 3 or grade 4, we call it as a dengue shock syndrome. Why we have to, it is important to distinguish between dengue fever or dengue hemorrhagic fever, because it's difficult to distinguish from the beginning. But in the dengue hemorrhagic fever, always there's plasma leakage. And dengue fever more often accompanied with symptoms such as headache, myalgia, retrobulbar pain, nausea, vomiting, and diarrhea. But dengue fever can also show bleeding. But pay attention, if we have the patient come in a fever of effervescent when the temperature is decreases, usually doctor or the patient suggests that's already convalescent, but it can severe. So this pay attention of the condition of fever at effervescent. And the prognosis of dengue fever is better than dengue hemorrhagic fever. The criteria of WHO 1997 of DSF is acute fevers 2 to 7 days with a minimal one sign of bleeding manifestation, such as rumble lead or a tourniquet test positive, with the thrombocytopenia below 100,000 per milliliter, and a minimal one sign of plasma leakage. We can see the hemoconcentration with the increase of hematocrit 20% or more compared to baseline, or the decrease of hematocrit more than 20% following fluid treatment, or the other sign of plasma leakage such as pleural effusion, ascites, hypoproteinemia, or hypoalbuminemia. This is the criteria for dengue hemorrhagic fever and dengue fever from WHO 2011. So some doctors still use the WHO 1997, and the others use the WHO 2011. We look here with the difference is in dengue fever there's no evidence of plasma leakage, but in dengue hemorrhagic fever there's a plasma leakage. Usually we can look, there's a hemoconcentration. This is the diagnostic tools for dengue virus infection. Usually we have dengue for NS1 antigen by immunochromatography or ELISA, and virus isolation by culture, but it needs time 1 to 3 weeks and RNA detection with PCR. Now the PCR already not just conventional, but also we have a real time to know the typing for the dengue virus. And for serology, we have IgG and IgM to differentiate between is it primary or secondary infection. If somebody have once a bite of Aedes aegypti with dengue virus inside, even is asymptomatic or this is undifferentiated fever or dengue fever, that is already primary infection. So at that time, the IgM will increase in the 3rd or 5 days and achieve the level, the peak levels in 2 weeks, and then decrease in 3 until 8 months. It's very long time. And the IgG in primary infection, it will increase in about 14 days. But if somebody pass again in the 2nd or the 3rd or the 4th, so we call secondary infection. At that time, the IgM secondary usually in the low level than the primary. We can look here. But in IgG, it will increase in the 2 or 3 days already high. This is the cause of dengue illness. This is if the patient suffer from fever, in the first day already viremia, and that time it's a good time for take for culture or for PCR or for NS1. But for IgM, need time, about 5 days or it will increase. And the IgG in the secondary, it will increase in the 2nd or 3 days. So what is the laboratory disorders in dengue hemorrhagic fever? Usually we mostly found is thrombocytopenia below 100,000, and also leukopenia and hemoconcentration usually on the day 3 to 4. And how to know there's a plasma leakage is from hemoconcentration or hypoalbuminemia that we can see in the chest X-ray. There is a pleural effusion or ascites, and also there is increasing of serum transaminase like AST more than ALT. And if there is a prolong of PPT or APTT, there is a risk of bleeding. This is the immune response of dengue infection. We see here that NS1 we can see from the first day of the fever, same like in the secondary, and IgM in the 5 or 3rd or 5 days, but in the secondary the level, the IgM level is not too high, not as high as a primary. So this is a mosquito bite. If somebody have fever, so perhaps the mosquito bites 4 or 7 days before. We know there's a culture for dengue virus. It needs time, 1 to 3 weeks, and the instruments are expensive and need the skilled laboratory technician. So that's why it is just for in the research, not for diagnosis. And how about for RT-PCR, retrospective test PCR? We still use for the conventional, but also we also have a real-time PCR. But there's the success for depends on the timing of serum sample taking. Usually in 3 days, within 3 or 3 days is the best, and need laboratory standardization. About the serological examination, the WHO still have as hemagglutination inhibition test, HI test, but it is difficult to make as a diagnosis because it needs two samples, acute samples, when the patient come to the hospital, and 7 days later, perhaps the patient already already at home, convalescent, or already die. So it's difficult to have the convalescent sample. So to test the HI is it difficult. And dengue blood, is it already, I think it's discontinued because we don't have again in the commercial kit in Indonesia, but we still have ELISA and also ICT. So ELISA and ICT still used for detection of IgM and IgG as well as NS1 antigen. We know that ICT is just qualitative, but in ELISA we can see quantitative, but usually the physician, the clinician, they like ICT because it's rapid. That is interpretation of HI test. We need acute and convalescent sera with the interval 7 days. If the titer below 1 to 1,280, it could be acute primary, but more than 1 to 2,560 is secondary. And the increase of titer more than 5 times. How about the ELISA? ELISA can, we use just a single serum, no need for per sera, but if we have per sera, the sensitivity and specificity will increase. How about the dengue rapid test? We know that dengue rapid test, the method is immunochromatography. We call also lateral flow test or simply strip test that developed by Singer and Plotz in 1956. And usually it is for screening tests. We know that we can detect NS1, IgG, IgM in one strip. And now there is IgA also, but it is not still not popular in my country. The method of immunochromatography is similar like ELISA, but we use in a nitrocellulose membrane, and the result is qualitative. But pay attention on interpretation on rapid test because of in our research, previous research in secondary infection, the appearance of IgG line is enough for showing secondary infection because we know that in the secondary infection, that is just the low titer of IgM level, so only 25 to 78% of positive IgM and acute secondary infection. But if the IgG is negative, but the positive just in IgM line is found, so be careful because it's not only primary infection, but if in the endemic area, like in my country, we have so many typhoid fever and also malaria, so it can also be false positive with suspicion of typhoid fever and malaria in endemic area, so that clinical signs have to be taken into consideration. Now about the IgA anti-dengue. I have to research in 2013 with my students, Dr. Resna, and there's my colleague, Dr. Erwin Internes, internal medicine doctor. We conduct in 75 samples with the immunochromatographic method. The objective is to assess the diagnostic performance of IgA anti-dengue rapid test as a new marker of dengue infection. And also we use NS1 antigen, IgM, IgG, dengue with ELISA. And this is the principle of IgA anti-dengue immunochromatography method. We know in the nitrocellulose membrane, it's coated by dengue virus, and then this is the sera that we suspicious of IgA anti-dengue from human sera, and the conjugate is good anti-human IgA anti-dengue colloidal code label, and they give color, purple pink color. And this is the interpretation of IgA anti-dengue immunochromatography. They have a intensity scale, color scale from 0 to 2, 0 to 5, 1 to 0, and 2.0, 3.0, and the considered positive is the color from 0 to 2. We need, there is a control line, and this is a test line. What is the characteristic of dengue, non-dengue virus samples? We also have malaria samples, typhoid fever, hepatitis A, pneumonia, UTI, and also leptospirosis. And there is some of malaria, typhoid, and hepatitis give the false positive. We look here in the figure that the frequency of the IgE. This is a day 1 to 2. We look in, this is in a secondary infection because more than 80% patient in Indonesia is already secondary infection. So IgA and IgG we can see in the, this is the first day, the first two days, but IgM still not yet, still just 50%, but NS1 not yet. Even in the brochure we know that NS1 can detect from the day 1. But in the day 3 or to 4, now we can see IgA, IgG, and also IgM. But the NS1 is still low. This is in secondary. This is my previous research with Dr. Sri Kartikasari, also my student at the time. So we can see here in primary infection, we look here. This is NS1. We know that NS1 in primary infection is good marker. So we can use NS1, but in secondary we use IgA, and then this is IgM number 2, and then NS1 is depend on the days. In my research, NS1 is better if we check in the day 3 or day 4. So there's the positivity of IgA in acute phase of secondary infection was the highest. This is the percentage of positive samples according to the days. So IgA-RT, this is from 19 positive, 18 is positive in the day 1. So it is similar with the previous slide. This is IgE, and then this is NS1 and IgG and IgM in the first day. See, the sensitivity performance is in the acute samples, the IgE is higher than IgM, and the third is IgG, and the last is NS1 in secondary. So because we know that in the endemic country of dengue, usually we found the secondary infection. So we looked at the positivity percentage of IgA was high in the acute phase sera of secondary infection, 91%. And according to the day's onset of symptoms, IgA rapid test can detect earlier than IgM and NS1. But precaution if positive for IgA, similar with IgM, precaution for typhoid fever, malaria, and hepatitis because it can be false positive. This is the diagnostic sensitivity, 83.8, and the specificity 81.1, sorry. This is the serological pattern in primary. We know that in the day 1, day 2, usually it is good if we know from the culture, the virus isolation, and PCR also NS1. But NS1, I think according to our research, we not recommended in the secondary infection in the first day, because usually just in the 3 or 4 days it will positive, but it will decrease rapidly. We can look here in the primary, the IgM in the 3 or 5 days, but the IgA already positive. IgM can last until 3 months to 8 months, but IgA just in 45 days. And the surgical pattern in secondary, this is IgG already high in the 2nd or 3rd days, and also with IgA. And IgM, we know there's a low level of IgM, so if we can do ELISA, it's better if we make a ratio between IgM over IgG. So this is our ongoing research. We have kit 4N1 dengue. There is NS1, IgA, IgM, and IgG with the gold standard PCR. Yeah. Okay. This is the algorithm from our association. Serology and in day 1, 2, 3, 4, 7. And also this is diagram of rapid diagnosis test from government using for primary health center. If below 5 days, so using the NS1 or IgA, and more than 5 days, IgM or IgG or IgA. So for conclusion, we have aware to the which day of fever. So we examine the complete blood count, leukopenia, thrombocytopenia, EST more than ELT, and also serology NS1, IgG, IgM, and IgA. So need to distinguish between primary and secondary, because we know that secondary is more important because can result in DSS. And then we know that for rapid tests, that is not for follow-up treatment. And we know that anti-dengue is not anti-DSF because it can also positive and also in dengue fever also. IgA anti-dengue rapid test can be considered as a new marker of dengue infection given the high sensitivity, especially in acute phase and secondary infection. Thank you.